Incisal reinforcement. What do I mean by that? I mean, if you take areas with extreme wear, which is usually you see in bruxing patients and things of that nature, you can if you don't have to do anything with tooth length and you've got good supportive enamel around it, then you can actually trough out those areas and replace it in the step-by-step sequence that you're going to see. And also, the thing you need to take a look at is the disclusion. And you see the wear on the canines, and that person has probably been in group function. You need to get a patient out of group function and get good disclusion so that you can prevent this from happening again. They may be clenchers, you don't know what they're doing, and if they need a night guard later on, then you're going to have to put them in a night guard. But this is the way I would do it. If you take a look at the laterals and centrals, they are troughed. You can see that there's an area that we've taken out of the dental area, and so that we can put it back in and replace it and get it to the color match that you want and to the incisal edge. So those areas are troughed, and this is the way it looks when it finishes. So let's go through the procedure. These are the micro burrs we're talking about. This is the broad-based micro burr that I might use to broaden out the base of the trough. But when I do it, I will enter with a flame-shaped micro burr. And you can see it's got a pointed tip, and that will get me into penetration. Then I can broaden it out with the straight fissure and broaden out the base. If you take a look, and if these areas had to be, I had to add the cusp tips, I could very easily go over the lingual surface and prep the labial surface to do that. And we did that. We did that on the canines, okay? And this, you can take a look. Now, in this particular instance, since I'm reestablishing canine disclusion, I'm going to long bevel the facial surface and take a little bit off the lingual to add to it, okay? But if we take a look what we've done on the laterals and the centrals, you can see the trough is in place. You can see now I've got the preps finished. I'm isolating with whatever you want to isolate with. I use metal strips. You can use Teflon, anything that's thin enough to get in there, because I'm going to do this in quadrant form. Okay, so now I can acid etch. And since I got the metal strip in there, I won't etch the adjacent tooth surface so they won't stick to one another. Then I wash it off, air thin it, and then I put on my bonding agent, bonding adhesive, air thin that. If you take a look at it, let's look under higher power. Look at the integrity of the surrounding enamel on the proximal, on the labial, on the buccal, facial, okay? And so so now all we're going to do is fill that area that's defective. I'm going to bring it back to the incisal edge. So the first thing I'm going to do is I would either put nano or microhybrid, depending on the color that's in there. Or you could, and if you need an opaque, you could do that. But what we're going to do, I'm using nano here because I think that's the one that's going to work. And I'll use the color of the nano, the color of the tooth. We place it, we shape it, we sculpt it. And now you see I'm using a multi-purpose instrument and the rounded end of the multi-purpose instrument because I'm going to make a concavity. And why am I making that concavity? Because I want to have some room for the microfil to go over the top, because that's going to give me the best wear resistance, the best margination, and the best long-term result. So we're troughing that area a little bit after I put in the nano. Now you can see the concavity in there that's placed. That gives us enough room. You polymerize that, and that gives us enough room for the layer of microfil, which goes over the top. This is a simple, fast procedure. This is amazing. And if you don't do it for your patients, you're making a mistake, okay? Because I don't want to see these wear down to nubbins and then do lower anterior crowns. That's the worst restoration you could possibly place. This is minimally invasive and it's fantastic and it's fast. So we'll carve it, sculpt it, shape it where we got it, and we can do that, polymerize that, and then we'll do all the other three. So now I can finish and polish in quadrant form, okay? And I will check it with a articulating paper, and outpatient going to excursive movements and protrusive, and you see interferences there, I know where to take it. Now I go to a disc. I will not go to a rotary instrument. I'll go to a porous disc, running it at about 10,000 RPMs, and I'll reduce that incisal contacts so that you have perfect exclusion and protrusive. So you can see how I'm doing it. I'm using the core stick first. That's what we'll do it. Then we go through fine, medium, medium, fine, and super fine. And then we might use a rubber wheel or a rubber cup to go over the facial surface a little bit towards the incisal facial and on the lingual. Interproximal, our finishing strips, diamond strips, and then we'll use our aluminum oxide strips, and then I'll use some Microfil. And you can see there's an interference on that lower patient's lower right central incisor. Yeah, that's heavy. Believe me, when they tell you they can feel that, they can feel it. If you take a look, we'll reduce that, and that's the way the patient finished. And you can see I've added the canine rise on there so that gets canine disclusion. Because if you hadn't wouldn't do that, then you'd have more problems later on. This way, we restored the disclusion so that so you don't have interferences. And that's the way it looks from the inside. If you take a look at this case, same thing. We did troughing, but there's areas where there's breakdown on the facial and lingual surfaces. So we're going to have to long bevel in those areas. But the same thing would be true no matter what color this was. And I think it was an A3. And so we used A3 in the nano or microhybrid. I don't know which one it was, but that's what I would use. And opaque it if necessary, then overlay it with Microfil. And you'd long bevel on the surface and bring it slightly down past the incisal edge onto the facial surface. And that's the way we looked when it finished it. So that is incisal troughing. Whether it's on the upper or the lower, this is really a great way to and it's a great for your practice. And there isn't anybody in your practice that shouldn't be treated this way, as far as I'm concerned. So let's go to diastema closure. Which ones are more difficult to do? The smaller ones or the bigger ones? Well, in my estimation, the smaller ones are much more difficult because you got to close that space. But believe me, when people say symmetry doesn't count, especially in the two centrals, forget it. As far as I'm concerned, I want to be symmetrical all the way along, if I can. That symmetry for me is king. So I would have to add little pieces into that interproximal area, those areas, and get them defined and make each tooth symmetrical. For God's sakes, in an area like this, don't add to one tooth, because that's what I used to see all the time, and it was a disaster when these cases came in. But let's take you through step by step, okay? In order to do that, let's see what we use. Bonding adhesives, yes. Microfil, absolutely. Microhide, never. Nano, if you're using it as a universal, okay, but that's optional. And opaques are seldom, and we'll tell you why. Let's look at this case right here. This is a diastema closure that was sent to me by an orthodontist after he'd set up the case. My good friend Bill Ford next door, who was a very inventive guy, and he asked me after watching. This is the way I got into aesthetic bonding, is because Bill saw me fix fractured anterior teeth for several years, and he said, he came over and says, "Can you close these spaces for me?" And I said, "Yeah, I probably can." I'd never thought about it, and I did. And this is the way we got started. So if you take a look, it was not this case, it was on another case, but if you take a look at this, what are you restoring here primarily if I'm going to reshape these teeth? It's enamel, okay? And so what do we restore enamel with? Microfil. What separates our Microfil from any other Microfils? Well, one of the wraps on Microfil, besides the chipping, okay, was the fact that it was too translucent. But we built opacity into our Microfil so that it blends into the enamel surface and it takes on the color so you can't believe it. And that's the difference between our Microfil and any other Microfil that's left out there, okay? So now we're going to prepare these teeth. And anytime I want to prepare the teeth and getting them prepared to etch and bond and get ready to biofilm, everything before we start, we always we do a prophylaxis. We never take shade on a tooth that has not been cleaned properly, but we want it moist. We don't desiccate the tooth. Remember, you want to take shade on a clean, moist tooth, okay? Then we go in the interproximal, get off any plaque with a diamond strip, 15 micron diamond strip. And then we'll measure for symmetry. And you can see this in older cases, an old Foley gauge, which I reshaped in order to make it work, okay? and I look at the cant, notice on the patient's upper left side, okay, that the cant is really pretty vertical, and that's what we want. If you take a look at the right side, it's got a mesial cant to it, and I want to straighten that out and create the illusion that it's uprighted. So I always take that into note. So we look at all of that, and you'll see that what we did in the finish case. Now, I don't have to prep this tooth in any way except acid etches. So I'll isolate with a mylar strip or anything else you want, etch to the middle third. And when you take a look at the etched tooth, you can see on the proximal there that there's an area that's unetched. Why? This patient had braces, had brackets on, and there was some of the cement left on. So I had to take it off, this area right here. Okay, so I gotta take that off, freshen it up, then go back and re-acid etch, put on my air thinner, put on my wash and dry it, put on my bonding adhesive. Bonding adhesive's in place. And now you can see this in older case because in those days, when I did the case, we didn't even have we had no nitrile. I was using latex. I was allergic to latex, so I had this guard underneath. Okay, so I wrote. That's an ellipse that we showed to. Let's go back here. I use convenience forms. In this particular case, I'm doing a diastema, so I make it in this sort of elliptical shape which will fit into, and I can place it on my instrument. And I do use my fingers to do that, and I can place it, start to shape it, and sculpt it, rather than just putting on a bulk of material and having to take the excess off. And so now you can see in this case, we didn't have the titanium coated instruments, but these are the Hugh Freedy instruments, chrome instruments in those days, which I used. And I'm going to start to sculpt it, shape it the way we talked about before. And you can see how the attention to detail, when I'm sculpting it underneath the free margin, looking at the line angles, paying attention to the proximal contours, and shaping it and blending it with this 8A instrument over the facial surface to blend it down to get a finite margin. Taking off the excesses, wiping off the excesses with my gauze, then making sure that the blade is unblemished, because you don't want it blemished like we talk about, because if it is blemished and or you have scratches and things like that, if you take it to the material, you can have a tendency to impact, have pullback and impact air. You want to make sure they're nice and clean all the time when you're working with these instruments. And you can see I've got the labial wall cured and in place to contour. Okay, it may be slightly overbulked from the facial, but from the proximal, it is to contour. If you look at the lingual, you can look at the lingual shelf. That's a void in there. Now I got to place that. I'm going to fill that with more microfil. Why microfil? Because that's all you're replacing is enamel surface. You don't need anything else. You want this. You want enamel. You don't want dent. So there we go. We go ahead. We place an ellipse of material into that void area, the lingual area, sculpt it, shape it, blend it, get it where we want it. And once we've got it that way, we measure before we finish to make sure that the tooth, that measurement is the same thing as the one on the other side, the tooth plus the space. And it's half the distance between for each tooth. So we measure, and then the thing I'm going to do, because I want to finish the first tooth, because then I can place the material in direct apposition, but I have a mylar strip in there after acid. So I go ahead and finish, polish, ET on the facial, OS1 on the lingual, go through my disking system to coarse, medium to fine to superfine. Interproximal finishing strip, start with a diamond, and then with a fine, superfine aluminum oxide strip. And that's what we use, aluminum oxide, because that's going to give you the best polish on a microfilm. And once we're done with that, now I take the strip out. I don't need it. It's been out there. Now I got a smooth surface to bond to, so it can't stick to the other surface. So now I place my microfil on the labial on the adjacent tooth, on the right central, and I will sculpt it, shape it, and get it where I want it, polymerize the facial aspect, and then go to the lingual, fill the lingual void. And you can see how these instruments, especially the titanium instruments, which are much finer than these, can sculpt beneath the gingival margin, getting a perfect lingual contour, and going up into the embrasure spaces and defining the embrasure spaces, and bring it onto the lingual surface. And the excess comes out. You can see that's still soft. Trim it out through the facial and get rid of the facial gingival excess with the IPC carver, and that's much thicker than the one we have right now. And that's the way it looks when we finish the application, and then we finish and polish. And the contact is so tight that I either do torquing or I can use the interproximal strip. But the torquing works if you're going to place the instrument. This is an 8A chrome instrument. I still use it, okay? I'll place it at the gingival, torque it one way. If it doesn't go, then torque it the other way. If it doesn't go, then you've got something impacted in the gingival. You have to clean out the gingival, and I guarantee it'll go. If you want to use an interproximal saw, that's excellent to do that with all too. Here we're using the 8392-016 to trim so beautifully. You can see how it fits along all the aspects of the lingual surface, and you can take it down beneath the free margin, running at about 3,500 RPM to trim that margin. On the labial, let's take a look. We retract back, and you can see there's excess here. And so I take that for running it and have a water drop. We run at 35 RPMs and take off the excess. Now, if I saw an area of defect in there and it was going the other way and there was an excess, then I would go in there, freshen up the defective area, put on bonding adhesives, and fill it, and then trim the gingival. Okay? So now we started this way, and this is the way we finish. Both centrals are uprighted, and you can take a look from side to side. And we take a look at the cannon of the canine. Now, through the illusion of composite bonding, we have uprighted that canine. Look at the other side. That's even more distally inclined. We're going to change that inclination. So we're doing restorative orthodontics to help the orthodontist finish his case. Now, believe me, it works both ways. The orthodontist many times has to help me set up the cases before I can do it. That's why it's so great to get with good orthodontists and work in conjunction with them. This is just another case. We'll do it very rapidly. If you take a look at this case, this is sent to me by another orthodontist. If you take a look, there's a finished case on a big strapping kid, and it's a very feminine look because of the lateral incisors and the shape of the centrals. But the spacing was proper, and if you take a look from going back towards the posterior, there's no negative space or anything else. All we had to do was work on those 4 teeth. And the one that sets up the whole one is the one on the patient's right central because it's too short. So that's the one I've got to work on first, and that's where that sets up the key for the puzzle to do this whole thing. Just looking at them side to side, you can see how feminine that looks. Now we have to do a little preparation because when the patient closes, they're in contact there. So I'm going to have to do slight preps on there to get enough space to allow me to do my restoration. But it's totally minimally invasive. Look at the preps. You can see on the patient's, I think it's a right central. The patient, you can see where I've done it to lengthen that central. Okay, I did the preparation, goes down both proximals. There's a little bit of prep on the lateral, and that's about it. Other than that, we didn't have to prep at all. So now, after the preparation of the patient's right central, we go ahead and we add the length in nano. I could use microhybrid or nano, but I felt that there was more translucent toward that incisal edge, and you're better to err on the side of more translucence than more opacity. So I decided to use a more translucent material, and I did, and you can see it is more translucent. So what are we going to do? That's polymerized. Now I'm going to add opaquer. So I add opaquer, gets rid of that hypertranslucency, And once I've done with that, I can add the microfil. So we add the microfil. So now you see, instead of a ovoid tooth, and what's more, what the shape is so important because if you can't get the shape, you're not going to get the realistic look that you're looking for. And so shape and form to me are so important, it's unbelievable. So I got the right central the way I wanted it. Now we're going to finish and polish it. And that's the way it looks. And you can see that we've added characterization. You see the reflectivity, the characterization we added. And now we do the rest of the case. So the 4 are done. This is post-op. You can see it's, I think it may be several weeks post-op. I don't know. I don't even remember, but look at the health of the gingival tissue now. Taking a look in profile. Can't even find them. Their restorations, they're invisible. That's what we're dealing with. Invisible restoration. And from the incisal. And that's diastema closure. So let's look at enamel defects. Well, if you take a look at this one, it looks like a big defect. But when I took the thing about it is, when you got a defect like this, you want to take it out of there. You must get it out of there like a cancer. You're not going to cover it up. You're going to take it out of there. So you're going to have to cut that out, prepare it. But when I took this one out, it was all an enamel lesion. So what did I do? Restore it with? The microfil of the color of choice, nothing else. And I got a total invisible restoration. But when it's deeper, it's something like this, and you'll see it. Okay? Let's look at this. It's a very deep lesion. It goes into the dent, and you can see it. And let's outline those areas. You see, if I would just put all microfil in there, those defects would shine through. So we got to bring those defects up to the undercolor of the surrounding a dentin, which matches basically the lower level, which matches the enamel. So we do. Now we got the undercolor matching the facial color. And that was done with a little microhybrid. And then we place our microfil. And then we finish and polish it. That's simple. Just remember, you got to remove the lesion. Let's take a look at this one. Here's a brown spot lesion. Probably there was an accident when the kid was in his deciduous teeth that damaged the tooth bud. And at that point where it was at the cervical, you can see where the damage was done, and then it repaired itself. I don't know. It's speculation. But in the meantime, we got it out of there. First thing you got to do is get it out of there like a cancer. Then you do a long bevel on both the incisal, a bevel on towards the incisal and towards the gingival. Then you will, if it's deep, which it was in this one, you will place either microhybrid or nano and opaquer if you need it to bring it up to the undercolor of the facial, to the color of the facial surface, and overlay with microfil. And that's what we did. You can characterize it the way you see it there. Here's another defect that you see. Okay, and your first thought would be, hey, I'll take that because there's a pit in there. That's why that's hypertrophy. Okay, so your first thought would be, maybe I'll just trim that off and then fill it. That's not the way to do it. We do what's called a restorative gingivectomy. In other words, I'm going to hold back that gingival tissue, long bevel the facial surface, acid etch it, and place microfil in there. That's exactly what we did. Okay, and then on the other tooth, we went through our procedure normally as a preparation and restoring it, and you'll see what happens with this. Let's take a look. Okay, all we did was reflect it back, long bevel, micro etch, place microfil. And that's the way it looked. And you can say, look, if the tooth is repaired, and you can't find them. That's what's so beautiful about this material. And there's all types of defects that you can repair, but this is the way we do it. We can also place defects, which we'll go through later on. We can make defects. Oops. All right. So now we're into veneering. This is what everybody mostly talks about, veneering in class 4. For me, I've shown you a bunch of things that will be so great in your practice, especially when you get back and people aren't doing these elective techniques, but they're going to be doing the things that I showed you aesthetically for sure. But when you get your practice gets active and everything else, if you want to do a composite veneer, don't anybody ever let them tell you they can't. Number one, I put it up against any porcelain veneer anytime, anyway. Okay, as far as color, as far as lifelike look, as far as the gingival integrity, it'll beat it to death. As far as long-term durability, as far as repairability, all these ways. Okay, so don't say that you can't. Okay, because you can. It depends on, if you don't ever want to do one, don't do one. But don't let anybody say they can't. So we're going to look at preparation because it's preparation is necessary as far as I'm concerned. And I would always, on any a veneer, I would always report a preparation. Even when I'm bringing something lingual forward, I got to have a margin to prep to. So in our preparation, we're going to prep from incisal to gingival, taking between 0.8 of a millimeter to 1 millimeter at the incisal, down to 0.3 of a millimeter at the gingival. We're going to take it interproximally, far enough to hide every single margin. We're going to end up with a chamfered margin interproximally and a chamfered margin gingival. I use the 6862 burr is really great for me. So when you see that, once we're done with the preparation, okay, and there's two preps. One when the incisal edge is tacked, and the other one is when it is. When do I leave the incisal edge attack? Any chance I get, because you're doing a veneer here. That's exactly what it is. I don't want to invade the incisal edge if I don't have to. I'll gently round it back towards the incisal lingual line angle. Okay, so now once we've done that, you'll either prep hybrid or nano on the facial. I prefer for most teeth to use the microhybrid because it blocks out in thinner layers. Okay, then once that's in place the way you've got it, then I'll opaque and tint where I need to. Okay, and once that's done, I'll place my body microfil, shape it, form it, and if I want to add more translucent and get more inside, I can leave an area where I can interscope for the incisal translucent, not penetrating into the hybrid layer, but making sure that I stay in the enamel layer, which is microfil. The second method of preparation is if the tooth is fractured or there's a need to lengthen the tooth or whatever you're going to do and you have to go over the lingual, then you'll prep it just like a fracture. And the facial, you'll prep like we just described. So in essence, it's a very similar prep, except we're leaving room to prep the incisal area. And so we've got our prep. You can see we've got it done. And now once it's done, we're going to add either hybrid, microhybrid, or nano to the incisal edge. Today, usually most of the time I'm using nano because of its handling properties. It's easier to place it. But remembering it's more translucent, so you may have to use more opaque. That's up to you and the color change you're doing. Okay? So once I get the incisal edge, the incisal sculpted, okay, and polymerized, and so I've got the length of the tooth the way I want it, then I'll do the facial aspect, starting with the nano or the microhybrid, whatever I think. Once we're done with that, we opaque it or tint it as necessary if we have to. Once we're done with that, we add the microfil layer. And once we're done with that, we intersculpt the microfil if we want to for more incisal, or I'll just let the tint shine through it. Most of the time, I'm a tinter, I let the tint do its job, but once in a while I'll intersculpt. A lot of people will use more incisal trans than I do as far as the incisal materials. That's up to you. That's up to what you see. Okay. So in preparation, you can either use depth cuts or you may be able to determine it by yourself. That's up to you. But if you need a depth cut, you can use this. This burr is a 8856 diamond, and it's at the tip of the burr, it's 1 millimeter. So I sink it a little bit less, which is about 0.8 of a millimeter, 7/8 of a millimeter. Okay, across the whole thing. And the most I'll do is 4 teeth at one time. Okay. And if the single teeth I need to do to set it up, I'll do the single tooth. but this is the way the depth cut looks along the incisal edge. And I'll take the 68-62 diamond, which I love for prepping because of the tip that I can make a perfect chamfered margin down at the gingival, and I'll prep it along the curvature of the convexity of the surface, so that I don't take it straight across and reduce too much. I want to follow and have a uniform thickness all the way down that surface. So I use my wrist. And one thing I didn't mention, you see the burr, the green area that's sticking out there? These burrs are too short. Don't stick them in all the way to the hub because you don't have access in there. So you got to stick it past the colored marker, and that will give you the length to get the access all the way down the tooth. And that's imperative. And that's every burr we're talking about. Okay? So now you can see me defining the gingival margin, taking it into the proximal with the tip. I will even make that horizontal to that to the interproximal area to get that tip in there to refine that margin. You can either feather edge it or you end with a chamfer. I prefer to end with a chamfer. You can tell you how to prep, you track back all the time. Now we've got our preps. You can see all four of them. Are they done? Not necessarily there. You want to hide every margin. You want to take it back far enough so you can't see anything. So I'll go to my little flame-shaped diamond and the micro diamond, and I'll get back into those areas, tuck that in so you can't see anything. From the incisal, you can see how it is, except at the incisal edge there, where you see that sharp edge at the facial incisal, I would just gently round it back so that you don't have any areas that might cause shearing. Just gently round it back towards the lingual incisal. Once we're done with that, you can place your strips in, whatever you're using, acid etch. And I'm acid etching. Remove the strip, and you can see that's totally an enamel. That strip is totally, and that's the best thing you get. Do we get into the dentin? Yes, I got into the dentin using first generation bonding agents that never had a problem. Okay, so these are fifth and fourth generation bonding agents. I'm a total etcher. That's what I am. You can see the etch and the quality of the etch on that too. Place my bonding adhesive, air thin it, and I'm ready to apply my microhybrid. So the B1 microhybrid goes to place because this is going to be a B1 tooth, and so I don't care about the color of the dentin. I'm taking the color of the dentin out of the scenario every single time because I'm going towards the external color. So we start with a B1 microhybrid. Sculpt it, shape it, thin it out, cleave it to the gingival, bring it back towards the incisal, thin it out, polymerize it, and you can see some dark areas in the proximal, which I may have to opaque, and that indentation at the facial surface there that I may block out, and I use that with opaque. A1, the color of the choice which I'm using. And then you look at it, and it's polymerized, and look at the thickness of that. Hardly anything is added. That's what's so beautiful about the microhybrid, is because it blocks out and it's easy to manipulate ultra thin layers. So now you can see those areas have been filled in and that's been polymerized. And now I'm adding my tip. Everything off the tip of the brush. And I'm sculpting it the way I would see it. And you don't want a straight line effect. That's very unsightly. Okay. You want to blend it up into the tooth the way you might see the mamelons develop. And the tin is in place. And I see the area at the incisal edge. I let that light area come through to try to develop a halo because this is a younger patient. So that's the way the tint looks, and that's where it's placed. This is the halo effect. There's your tint. And once I'm done with that, polymerize it. Now I go on with my microfil. You know what to do with the microfil. You're going to place it with a heavier instrument. Now these are titanium coated. We're going to sculpt it, shape it, get it where we want it, transferring to an 8A. And that's a heavy instrument, but gives me more definition and allows me to go in areas where I can't get the G3, sculpting beneath the free margin, pushing it gently beneath the free margin. Then once I get it where I want it, the shape where I want it, and actually the material on there, then I will transfer to the IPC so I can make my definitive uh, preparation and definitive finish. Okay, the IPC, place it, shape it, sculpting out the excesses, and you can see how that tooth takes shape and how beautiful that looks. Even now, we're not even polymerized yet. Here I'm trying to do the longitudinal characterization. I will do that many times. Sometimes I do it. Sometimes I do it in my polishing. Depends on how I feel, and that depends on what you want to do. You can see it's characterized. You see the way you can see the individual lobes, and we polymerize it. And the one thing I do that I always have done is I've always closed down the cervical margins. Everybody asks me about how you get good margins, and why I always have is because I always take after I've got my initial material on there and it's polymerized. I knew I couldn't do it in a single layer. No way could I get the margin as definitive as I wanted to. So I always, at the cervical area, put on another ellipse material against the pre-polymerized materials, sculpted it, shaped it, tucking under the free margin, closing down the gingival margin, and now I've got it closed. So now we're ready to finish it and polish it. So we go through the whole thing, ET, look at the different angulations of the burrs in order to to finish that material the way you want it, get the contours that you want on that tooth surface. So if you want to contour the incisor, you're going to tip that blade and go towards the wider portion. If you want to go towards the gingival, you got to tip it out away from the tooth and go towards the gingival. That's how you get curved surfaces with a straight blade. Now, if we retract back the gingival tissue, let's take a look at this. Look at that margin. It's a great margin, but it's raised. I got to finish that margin down to the cemental or the dental enamel junction, whichever one it is. Okay, I'm going to finish, and that's the way I'm going to do it. And you can see. Let's look at that here. I retract back, and now you see that margin is being finished. Now do it under copious amounts of water, usually a water drop with the patient water dropping it and drying it, or water spray, whichever one you prefer. I'm going to trim them at 3,500 to 4,500 RPMs. I'm going to trim that margin with an electric handpiece, okay, or a slow feed handpiece, always using retraction. And I can see it because I'm wearing optics. You know what I'm using. Going back to 16 fluted now. I'm going to smooth the tooth up more completely. I'm going to work on. I'm going to do my incisal edge with our disking system, and go in the interproximal areas with our disc system. Use our rubber points and cups to refine the grooves and refine the lobes. I may use my points, both medium and superfine. Interproximally, start with the strip, and then go in with a fine, superfine aluminum oxide strip. Beneath the free margin, we have a narrow one. So that wide one, I don't take beneath the free margin. We take the narrow one because that won't violate the integrity of the tissue. Now, once we're done, you can see how that looks from the facial surface. You can see the grooves. You can see the lobes. You can see it from the incisal, and you can see the thickness of the incisal edge. So when they're all done, this is the look that you get 2 weeks post-op. After bleaching lower anteriors, you got a much better look. This is the way she looked when she finished. This is the way she looked at 4 years after she finished her schooling at what's the school in New Orleans, Joan? Tulane, after she finished Tulane. Okay, so here's another way you can do it. This will go very quick. This is a depth cut too. You can use the 6862 diamond. The hub is about 1 millimeter thick. I think it's sinking in a little less than 1 millimeter to about 0.8 of a millimeter, and it'll run it down the curvature of that tooth. You can see me tipping the burr out towards the gingival. They have to give us 0.3 of a millimeter depth cut. We prep it. You could look down the incisal, following the curvature of the tooth. Then we prep from one side of the depth cut into the interproximal and to the gingival. Copious amounts of water while we're doing it. And we erase out the depth cut, and we're into the interproximal the way you want to, hiding all the margins. We'll go the other direction. And notice the angulations of the burr. Very important, because if you don't angulate it the right way, you're going to remove too much tooth structure. That's why I use electric handpiece, because I got complete control, and I can see everything I'm doing. Here I've got it tipped away from the tooth, making the chamfer down at the gingival, retracting back to gingival, getting even a better margin with the flame-shaped microdiamond underwater. And I need to add a little canine liftoff. So here I'm prepping the lingual. Now we've got it all prepped. Take a look at the lingual where I've left room so I can add that area where I can get canine rise. That's the way it looks in an acid, and that's all in an acid edge. But when I put my Bonnegeese on, it's very dark there, down at the gingival. So I say, you know, I've got to bring that value up, because if I just go ahead and work on that tooth, I'm not going to get the value up. I'm going to do that. We do it with pink opaque. We've known for years, lab men have known for years that pink will lift the value without over raising the value. If I use white down there or something like that, I will have a tendency to get too much value. So in this particular instance, we were the first ones ever to develop pink opaque for in composite, and many years later people have copied it, but it's not like ours. And you go ahead and you place that on. What you're going to do is just neutralize that area. You don't have to block it out completely. You can see how it's on. We got it blocked out the way I want to. There's still a little darkness shining through, but that is just enough to neutralize that area. Okay, and you'll see it later on when I work. I might put more on when I'm working with a tetracycline stained tooth, but this just enough to neutralize it, bring up that value without making hyper value down there. Okay, so now once we've done that, on goes the microhybrid. Watch it bend, watch it shape. Watch me, and I'm doing it with an 8A instrument, and I'm blending it over the tooth surface, shaping it, forming it, and watch it bend towards the proximal, taking the shape of the tooth. That's what's so beautiful about this stuff. Use a heavy material, you can't do it. It's more difficult. Takes you too long. This is rapid, this is fast, and simple. So we're sculpting it, closing down all our margins, okay? And once I've done that, all right, I notice there's an area up towards the gingival that you can see that I need to block out. And instead of adding material, it's easier just to add opaque in there. You can add material, do either what you want. It's much easier for me to add the opaque of the color of the tooth I'm working with, and I'll add it in, and that's the way the underlayer looks. And now we're ready to overlay with our microfil or do the things we need to do, tint and do anything you want, and then overlay with microfil. That's the finished restoration. We won't go through this right now because it gets you to think out of the box. If I get an opportunity, we'll do that. We got too much to go through, okay? Cuspid rise. If you take a look, you can see the flattening of that canine. Everybody wants to know how we take care of that. You can see that on the right patient's right side, there's an area where the cusp is completely flattened off. Patient came to me and wanted veneers. And I said, well, you need to have this because I can't do it. I can't do your veneers unless I take care of the canine. The canine. If you take a look, he goes into disclusion and he's writing on his centrals and laterals. I need to do the canine. In order to do this, I need to do the canine first before I do the central and lateral. So I will, and I told him, he said, but I don't want to veneer it. I said, okay, I can blend it back in, but I'm going to establish canine rise. So we'll prep it, we'll do it on the long bevel, on the labial, a little bit of prep on the lingual. Here we're using an application of Renamel Nano to restore that length. After we placed our bonding adhesive, shape it, form it, get it where you want it, bring it over onto the lingual, have the patient bite into it. You can have me bite into centric, separate their lips, and both are dry, and you can get centric and polarize right through that. Okay? Then we got the tip in place. Then we place our microfil. And if you take a look at what we've done, look at the embrasure space, the definition, look at the shape of the tooth, how we shaped it the way we want it. The prominence is towards the center of that tooth and follows like a triangular shape back in toward the interproximal areas. So we get perfect embrasure space, clean and neat. Cleanliness is next to godliness. You want it neat all the way, okay? You don't have to take it off in your polishing. So that when we polish, we got the right canine, the left canine, you got perfect canine disclusion, which allowed me then, because I did the disclusion first, would allow me then to do the rest of the case. And he wanted lighter teeth, but I blended it back in as best we could. And that allowed me to do the rest of the case. You can see the translucency, incisal, and things of that nature. And that's the way that fits. So we're going to bypass, well, we got time for reshaping alignment. Let's do it real quick. It's important. And let's look at it. If you take a look, this is what I'm talking about. Those are reshaped and realigned. But let's go through this case. This is a case that came to me. I sent her to an orthodontist. The orthodontist sent to the oral surgeon. You can see she got a retracted upper arch, really tight in there. And they wanted to do orthodontic surgery and everything. She wouldn't do it. She wouldn't do the ortho either. So I said, I can do this restoratively, but you're going to be slightly percumbent. She said, okay. And I said, I'm going to fill out your arch form from the standpoint of its narrowness. I'm going to give you a broader smile. She said, fine. Well, I pre-reached the lower anterior teeth to about an A1. Okay. Then we take a look at these. You'll never see margins like you just there's no reason ever to get margins like that on anything. So anyway, what's the tooth that sets up the whole case? The tooth that sets up the whole case is this little is the patient's upper left central, okay, or upper right central, right? And I'm gonna set the whole case on that. And so I can just outline that. Like if you want to do it and articulate or whatever you want, I don't have to because I see it. Okay, I just don't have to. That's up to you. You can do what you want. But I know the case that the tooth that's going to give me the biggest problem is that procumbent central. So it's going to be a more aggressive prep, which you can see. So it is a more aggressive prep. I'm doing the first 4 teeth against the arch, and that's what we'll do the first day. See, they're 4 prepped. Okay, over the incisal like we have, and that upper patient's upper, I think it's the upper right central is the precumbent. Yes, the upper patient's upper right central is the precumbent one. I do that first. Then that is the key to the puzzle. That sets up where every other tooth is aligned. Okay, once I get that done and finish, okay, now I can do the next one to it. And so the first day, okay, this is what she ends up with, and this is 1 week post-op. I've got A1. You see the translucency of the incisal. She didn't want any gingival color down there, so we didn't put it in. Okay, but that's 1 week of healing. That's the first 4 veneers, composite veneers, done after 1 week. Now you can see the narrow and the arch, the negative space up there. We got to fill that out to broaden her smile. So that's what we're going to do, and that's what we did. We filled it out, and that's a 1-year post-op on that case. Now let's look at it later on. What's it look like 10 years down the line? It's a 10-year post-op. It's a B1. Now this is taken with that was taken with analog camera. This was taken with a digital camera, so the colors are a little bit different. But the colors, they look pure, but they're not different. If you take a look at this, and it was B1, and that is a B1 shade gap, and that's it. But look at the health of the gingival tissue after 10 years. What can I tell you? Okay. And we're going to get out of here right now. We may come back to it. And we're going to go to repairs because everybody wants to know about repairs. Okay. What type of repairs? Metal, composite, porcelain. Let's go to metal. Why, Dr. Mopper? Because you know what? People want people want metal repaired, or they should have. Here are great inlays, terrific inlays, but there's some defects that you can see towards the incisal edge, things of that nature. And the patient didn't want it. They wanted to get rid of that exposed gold in their smile. Plus the fact you can see that old amalgam in there. So this, in one day, we changed the whole look back here, okay? We repaired the metal of that you see, and I got rid of the old amalgam in there. I took it out, long beveled it, did it the way we wanted. We did it that we discussed previously, and then we went and we did the metal. Okay, so now you see I've got the lateral repaired, and not the same day. Going to prep back the metal, just bevel a little bit on the enamel, acid etch it because it's total etch, and this is precious metal, so I don't have to use pink opaque on precious. That you don't have to do. On warm metal, you don't have to do it. So then I put on my bonding adhesive, my primer, my bead primer on the metal, and then we go ahead and or I put my dentin enamel primer on the whole thing, and then we go ahead and we apply our opaquer as needed. And you see, I've opaqued it out. First of all, let's go back through this again. First of all, let me say this again. We put our dentin enamel primer on the metal. Then we polymerize that. Then we put on our microhybrid. This is the microhybrid layer attack. And you can see there's some translucency shining through. I would, at this point, put the opaquer on of the color that we're using. Now the opaquer goes on. Polymerize the opaquer, then put on the microfil. And polish it. So that's a metal repair. You can see the way it looks under as it goes all the way back. They're invisible, actually, basically. And here's something that you see all the time with gingival recession along a porcelain of metal crown or a porcelain crown. And this can be repaired. This is done by my partner, Dennis Hartley. He roughened up the dental sclerotic zone. He did a long prep on the facial of the porcelain. He used Ginger Guard, which is our rubber dam material. Actually, it's a temporary rubber dam material. It just flex it off after you place it. Protects the gingival tissue. Put on hydrofluoric acid, 9.5% for about. This is self-pathic, so it's about 3 minutes, 3.5 minutes. Acid etch that. Then he put silinator on it. Then he went down and acid etched the gingival tissue with phosphoric acid. Then he put bonding adhesive over the whole thing. Then the opaquer layer, you can see nicely defined is the way he sculpted it. He used gingival retraction cord. Now he's got an application of microhybrid in place and overlaid with microfil and finished and polished. If we go to access areas like this, he put the microhybrid down first. I might put the opaquer down first, the pink opaque. But over the top of the microhybrid goes the pink opaque. It's a little bright. If you may have done the pink opaque first and the microhybrid, then the regular opaquer, may not have been quite so bright, but it's still a beautiful result. That's the way it looks with tinted. That's the way it looks polished. That's a beautiful result on access area. And composite. Now, if you take a look at this is a patient 12.5 years after I'd done this. He's a periodontist wife. And I had done right. What you see up there at the gingival was an attempt to make gingival material, and I gerrymandered that. Today, we were the first ones ever to come out with a gingival colored material called Gingival, and it's a great material. And if you can't add or graft or anything else like that, it's a great material to mimic the gingival tissue and get the pink to relate to the white. So in this particular instance, okay, she came to me with 2 chips in this tooth after 12.5 years. I hadn't even seen her. And she wanted to repair it. So we repaired them. How did we do this? So this incisor was chipped. I went ahead and freshened up the area, got into the dentin, okay, and the tooth surface, long beveled the composite area, okay, prepped the dental area, acid etched the dental area. You can't etch the composite. You don't want to micro etch the microfil. It's not going to do. It's going to be. It won't hold as well as just using the burr cut. So we go ahead and acid etch the dental area. Put our bonding adhesive and the dentin enamel primer into the dental areas and unfilled resin if you want the best of all results on the tooth structure on the composite. Then I look back at my records, and I had used opaquer in these areas, not any other material. We didn't have the materials in those days. So I went ahead and I used the opaquer of the color of choice, which is an A1B1. Glimmerize that, bringing the opaquer up to the middle of the long bevel, like I used to describe it all the time. Glimmerize that, and I use my Microfil. And this was a super bright. This is our white, actually, material. We sculpted it, shaped it, got it where we wanted it, finished and polished it. And there's a difference between finishing, contouring, finishing, and problem. Contouring means you contour to the shape. Finishing means you get things finished down from one restoration to another, so it's a finite margin. And polishing is where you go through the final steps. So here you can see me contouring. Then you can see that raised white line area. I don't want that. I'm going to take it out of there. I'm going to run it usually underwater a little bit, things of that nature. I'm going to try to get that down as best I can with the ET burr. Then I'll follow it up with a coarse disc, which is going to take it into the one material into the other, and running it at about 7,000 RPMs, you'll just see that white line disappear. And if you run it very slowly, you will not over contour. That's what you're worried about is over contour. But then you go through the rest of the finishing system, interfractional strip, finishing it. That's the way it looks. How long has it been? Now we'll go just a little long. I'll just show you this. It's not just me. This is Bob Margis. This is the type of work he does. These guys are masters, okay? They're all using similar techniques, similar material. This Corky Wilhite, most of you know who he is. He's been out on the circuit for a long time. This is the kind of work he does. Jimmy Eubanks, some of you may know him. He's my contemporary of mine, basically, a little younger than I am. He took my course in my basement. This is the way, and he was next lab technician before being a dentist. This is what he did. This is that kind of work he did immediately after taking my course the next week. This gal turned out to be Miss Texas. Jimmy said he couldn't have done this without the use of pink opaque, the unsightly non-vital tooth. Jason Smithson from England, the type of work he does. That's magnificent. Dennis Hartley, my partner, longtime partner. That's the type of work that he does. Look at the reflection, look at the refraction, look at the color, look at the gingival tissue. It's remarkable. And there are other people, so many people around the world, and eventually we get into question and answer session. I'll tell you who they are that do this same type of work. Long-term results, we'll go through it very quickly. How long do they last? Let's see. Let's take a look at this. This is 5 years. This is all my work. 5 years. Let's take a look at this. This is 9 years. On the grayish side, this is done with C1, blended back to the C2. These are 4 teeth against the arch. 9 years. Let's take a look at the higher power. Look at the gingival tissue. 9 years. Look at the incised ledges. You can see the translucent shining through. The tissue, the tooth shape, the tooth form. That's what's so important. Morphology is so important. Morphology is the most important aspect of the whole thing. If you can't make a tooth look like a tooth, forget the color. You got to be able to make a tooth look like a tooth. That's why I place so much emphasis on sculpting, shaping the contour, and finishing and polishing. Mutilated dentition, 10 years later. This is 4 teeth against an arch. 8 years. Now you can see a little defect on the gingival of that right central. So we repaired that. It was easy to do. Now the patient comes back. Same patient. I hadn't seen her for years. 19 years later, she's been out in California. She wanted, this is the same patient, A2, it's A2, but she came back because you see the spaces, she had orthodontic. She wanted me to fill those. I said, I can do that. I can repair all. She said, I don't want to repair. I said, what are you talking about? I don't want to repair, Dr. Mopper. I want lighter, brighter teeth. I said, okay, I'll give you lighter, brighter teeth. So I gave her lighter, brighter teeth against those darker teeth. So what did I do? Well, I bleached them, okay? But I gave her lighter, brighter teeth. Made her happy. Okay, so now we brighten them up. This 18 months post-op looked a little dark to me at that point. So maybe we'll re-bleach them when you come back at the next recall. You can see what we've done. And look at this. This is 2 years later. Look at the health of the gingival tissue. The lower teeth need to be bright. So that's at 2 years on the left side of the screen. You can see they're darker. Take a look at the right. Now we bleached them and then we got them brighter. Okay. This is the same patient. 2 years, 5 years, 9 years. Diastema closure. 10 years. 10 years. You can't find them. Look again. Oh, I guess I went back. Let's go here. Look at the spacing. I didn't do orthodontics or anything on it. I just reshaped the teeth. And I worked on all 4 teeth. Ex-hygienist of mine. He lives in Detroit, I think. Tissue management. Hey, the tissue is very important to me. Pink is just as important as white. And every place we can replace the pink with grafting, things of that nature, we're going to try to do that. This is a post-op 5.5 years. It's a Polaroid because I didn't have anything else at that time. But she comes back, okay? What I had done, let's go back here again. This is the way the case presented to me from the orthodontist. She wanted the 4 teeth bonded and changed, which we did, okay? But at 5.5 years, let's look. This is the way she started, okay? And I told her, if you take a look at the patient's upper right canine, you can see the tissue, they need grafting. And I told her you needed to graft it. I won't do it any other way. She said, no, just leave it and don't worry about it. Just do the 4 teeth. I said, okay. So I did. And when she came back at 5.5 years, all right, I said, she said, can you fix the 2 canines? I said, no, I'm not going to do it with composite. It won't look right. I want it grafted. She said, so she submitted to that. So I went ahead, sent her to my friendly periodontist, okay? And this is the way it looked at 1 year after he grafted her. This is the way the other side looked after 1 year after he grafted her. Look how beautiful that is. If I'd have done it the other way, she'd have been long in the tooth of canines, which would not be good. And it didn't have an effect. But this overall effect is beautiful. And then you look at it in relationship to the composite veneers I placed. Now the composite veneers are 6.5 years old, and that's the way she looked. That's the way she started, and that's the way she looks at 6.5 years. 26 years post-op. This is not my microfil. This is Silex. It was 3M's microfil, but I used it 26 years old. Not bad for 26 years old. Okay, tried to match the color. I think the color was you. They didn't match a Vita shaded guide in those days. We were the first ones ever to match the Vita shade guide. And we're the only ones that do match the Vita shade guide. Most of the other materials made their own shade guide. I like it because the Vita shade guide matches tooth against tooth, tooth against a material, tooth against composite, tooth against porcelain. It's just a great shade guide. And if you take a look at this one, these are different materials, and it goes back a long time. So this patient came in because if you look at the patient upper right central, you can see that craze line in there. that was fractured. She glued it on with super glue. She said, Dr. Mopper, can you fix my teeth? I said, yes, I can, but let's take a look. What's in there? Okay. 1981, Helicid. That was a microfil. 1981. I hadn't seen her since 1981. Well, I did over a period of years because I placed it this way. So now in 1985, she comes back. We placed Durafil. Okay. And then in 1989, we did this one in Renamel Microfil. So there's 3 different microfils on there, but they're all fairly polished. Looking at the Renamel Microfil, it's totally polished. Okay, and I realize the other ones have been on there longer, but that's the way it looks. Okay. And if you take a look at this one, this is a Polaroid. This is the way the patient presented with diastema closure and different canting of teeth and things of that nature. So we changed her a little bit, uprighted the laterals, changed the shape, and she came back because she had that chip at the incisal edge and that little stain at the gingival of the upper right lateral. And so we repaired her. Simple. Took 2 seconds. So that, ladies and gentlemen, concludes the seminar for now, and I'll be glad to take questions.
Okay, hey, buddy.
Yeah.
Okay, so this is Bennett again, and let me get over to the questions. We have about 30 questions. And
Okay.
if we don't get to all of them, we will definitely be doing answers to the questions in our follow-up emails.
Do I have to start this right here? Right here?
Yeah, I think I did it. All right. All right. So close that. I see your forehead, buddy.
My forehead. I don't
Yeah,
see
there
anything.
you go.
I don't see you. I have nothing
Okay,
on.
I'm not on. Let me just go down and get my video should be on. I don't know why it's not, but
There you are. I see you.
got it? Okay, good.
You see me?
Yeah, I can see
There
you.
we go. Here,
Okay.
now you see me. That's great.
All right, so
Hello,
I'm going over to the questions right here. All right.
Okay.
All right. So anyway, Peter Vavanos, he's from Maine, and I know Peter. He's a great guy. Been to the center a couple times. Wanted to know, what if we only use a microhybrid for the strengths? He was nervous about using the microfil, and this is in reference to your incisal troughing. He was nervous the microfil might break.
Microfil never breaks. You don't use it for the troughing. You can do microhybrid. If you use microhybrid only, you're going to get. It's not going to finish properly. You're going to have. It's going to overwear. You're not going to get the results. Don't forget, I placed either microhybrid or nano down in that trough. The only thing that is on there, the overlay, is a microfil. It's not going to break. It can't break because it's adhered to the microhybrid. It won't break. It won't break. It won't wear, and it won't wear adjacent teeth because that's the most polishable material you can get. That's what you want on that surface.
Great. And VJ wanted to know, how would you compare composite veneers to porcelain veneers?
How would I compare them? What did you hear? My partner came to me so many years ago, 90% of the stuff, he didn't even do composite. So now 90% of the anterior veneers he does, anterior stuff, is done in composite. How do I think it compares? I think it's superior in every way. In tissue integrity, okay? Maybe not in strength. It may be a little bit stronger, but as far as durability and lifelikeness and quality of color and everything else and the way it looks naturally in light, it far surpasses the cold look of porcelain.
All right, great. Tim Webb wanted to know if you use the same shade of nanofil and microfil when layering.
Pardon?
Tim Webb wanted to know, do you use the same shade of nanofil and microfil when you're doing the layering?
Yeah, because here's what I'm doing. I don't know if he was on the first one or not, but we take the color of the Denton shade out of the scenario. We're like I said, we're going toward the external shade. So if the tooth color is A1, I'm using an A1 nano and an A1 microfil, or an A1 microhybrid and an A1 microfil.
And then Chloe Cuvelin wanted to know, how come it doesn't stick to the opposite surface?
It can't stick to the opposite surface because there's no etch and no blemish, okay? And if the surface is polished, it won't stick. It can't. It's logic. That's how I developed it. It can't stick because you got to have a blemish to stick.
All right, good. Here's from my computer. I'm not sure, I saw a couple of those, but they'll recognize the question. Is the fact that Cosmonet Microfil has the same opacity to it the reason that the value of the diastema closure does not decrease?
That's right. It's because we increase the opacity
Hang
to
on a second, but
replicate the enamel surface.
Let me finish the question. I've used enamel shades of other companies to close diastemas before, and it ends up looking too dark.
That's right. It's too translucent because they're all translucent. And you're using enamel shades probably of nanofil. They're way too translucent. Ours has opacity, which takes on the color of the tooth structure. That's why you do it. That's why you don't, in a normal diastema closure that's not replacing dentin, you don't have to use anything but microfil. If I play a numbers game, if it's a real wide one and I close it down and there's a little shine through, all I do is cut back the microfil, opaque it out, and then overlay it with the same shade of microfil. And that, I've hardly ever done that. I can't remember when I've done that.
And when you say, just to clarify, buddy, when you say opaquer, you would use the creative color opaquer on that, correct?
That's the creative color, and the beauty of the creative color opacers is they're calibrated to the whole scenario of the system. It's a system. It works for you systematically. That's what you need. It is a cookbook for success. And so the microfills, the nanofills, the opacers, and the microhybrids, they all match each other, and they match an existing shade guide, which is the best one in the world, and that's Vita.
All right, great. Sophia Villanueva wants to know, if you get bleeding, what do you do?
If I get bleeding, I will back up, okay? And if I have to tack retraction cord, I will. I'll dry it. I'll put an astringent on it for sure, okay? And I'll tack retraction cord. If I get if I get a little, even when I get a little blood that seeps through the gingival, I'll put a little bit of water spray on it, not just a water drop on it, gently air dry it, and take a look at it. If that doesn't seep underneath anything and get that purple effect, which you see when it really seeps under it, I may continue. But that doesn't. But the interclavicular fluids, I don't worry anything about. I just blow them away gently. Remember, your air syringe is not a weapon. Tell that to your assistants too. You just don't blow it on the tooth and things like that. That causes irritation. You do everything gently under control.
All right, great. PC Chang wants to know, do you build these as composite veneers or three surface interior composites?
They're built in our places as composite veneers. And you'll have to ask go and call Dennis Hartley, because that's my staff. I don't practice anymore. 3 years ago, I developed a tremor, a essential tremor, so I gave up practice. Unbeknownst to me, I got rid of the tremor. If anybody wants to know later on, they can contact me. Unbelievable. You don't get rid of essential tremors, but I had a great doctor who got rid of it for me, so I could still practice. But what was the question again?
Oh, you wanted to know about billing. Was it veneer?
Well, billing, and so we bill as a veneer.
Okay, great. So Hal Burton, he actually asked me several questions, one of which was when we're going to start teaching at the center again, because he saw you in New York and really wants to sign up again to come to Chicago.
We're going to teach at the center as soon as it's safe for everybody to come in, and we're going to change our schedule. I guarantee you we'll be back in the fall. All our opinion leaders who lecture there will be there. I will be there. Cosmonet is there to help everybody. All we want them is safe, sound, and healthy.
And he also had a technical question, and that was, what do you use to reflect the enamel defect? And I think what he means by that is, what products are you used to create the defect?
Oh, if I create the defect, I will use my tints, like if I use a craze line, and I'm going to try to get into that next session, okay? I can create a craze line by, for instance, taking the one that's discolored. I can take my fine IPC carver, trace it down while the material is still soft, and then flow our tint, our brown tint, or whatever we want, into that area, gently compress it with my finger, and you'll see the excess coming out. We brush it out and polymerize it and polish it. And the tints and the opaquers are polishable because they're filled with microfil and they're polishable. So you got them trapped in there. They can't go anywhere. And I can produce white spots externally, or I can produce it underneath. I can produce craze lines, check lines, anything you want. And that's how we do it.
Great. And a follow-up question from Sophia was, how do you reflect the gingiva?
I retract the gingiva with you remember the chrome instruments I showed in the presentation? Those are, I think I get them from Hugh 3D, and I use the 8A instrument, which is a chrome instrument, and I use it because that's not near as expensive, and I don't want to mar and hurt my titanium coated instruments. So I use that instrument to retract, just hold it back and retract it. There are retraction instruments out there, by the way. I don't really like most of them. I like that 8A instrument, and I'll retract, hold with one hand, and refine with the other. While my assistant is dropping water drop and air drying it, water drop, air drying it. So I've got retraction, and that's how I do it. And I see it because I'm working under 4.5x optic.
Okay, and then Loudon had a question about opaquing. Why not just use opaque to block the undercolor?
I could, but that's very tedious. That's why when we developed the microhybrid, I realized it had opaquing qualities that were unbelievable. And it's much easier to do than try to block out with opaquer the whole two surface. That's very tough to do and takes a lot of time. And then it was really time consuming, but this shortened my time period down so much because the microhybrid blocks out in such ultra thin layers. You could do it with opaquer all the way, but it's tedious.
Okay, great.
That's a great question, because that's the way I used to do it before we had the microhybrid.
Mm-hmm.
It was opaquer, then microfil.
So Stephanie S. noticed that you use a brush with your composite when you're opaquing and tinting. She wants to know, how do you clean them?
We have we have a brush cleaner, and then we wipe it off with alcohol, and we put it in a cold sterilizer. Okay. Now I'm going to give you an example. All right. It's just a brush. We're cleaning it, and you wipe it. Now, if you can cleanse your hands with an alcohol wipe, okay, and get rid of most of the bacteria, then when you're putting in a cold sterilizer, whatever you do, that's going to kill everything. Now, I can't autoclave it because it'll ruin the brush. And I need this brush because the brushes that we use are unbelievable. They're not like any brush you ever use because they work like when you use them, the hairs go together and they leave virtually no brush strokes or anything like that. And they cost some money. And so we put them in a cold sterilizer, okay? Then we take them out, we wipe them out with a little alcohol, and we'll have it overnight. And here, let me give you an example. I'll use this as an example all the time. Anybody ever had a colonoscopy out there? It's about 6 foot long. How do they cold sterilize it? How do they sterilize it? They cold sterilize it, okay? All right? And if they can do that with something that they shove into my rear end, okay, and that's the only way I can say it, then what's a little brush tip going to do on a brush? And believe me, these are sterile.
I just want to clarify one thing too, because I'm not sure if Stephanie is from Canada, but they have very, very stringent hygiene requirements in Canada that preclude the use of the cold sterilizer.
Well, so then she's going to have to wipe them off, use the brush cleaner and wipe them off with alcohol and go with that, or she can't use our brush.
Yeah. Now, Sophia wanted to know, how do you polish the cervical area in order to avoid flash?
In order to avoid flash? I never get flash.
Right.
Because if you notice, I retract back the gingival tissue, use my 8392-016 burr to refine the margin, and I never get flash because I get perfect margination. Notice, I close the margin down the same way I did on the facial surface of the veneer. The same thing at the gingival. of a cervical. I always close down the cervical margin. There isn't a raised margin. Then I take my 8392-016 diamond, go down beneath the free margin, copious amounts of water, and finally do that. Then I'll take a rubber cup and polish out that surface with the use of disc. That's how we get it. And you got to get it with the 8392-016 before you start the polish.
All right, great. Deneen Zook wanted to know, when you restore canine rise, what do you code for this procedure?
You do it like a fracture, because that's what it is. You're lengthening the tooth. It's that would be a three-surface composite. That's what it is. You got a facial, a lingual, I know there's a lot of things on insurance. You got to remember, insurance is not going to pay what it's worth. And I'll tell you about charging, okay? You got to look at yourself. You know, what bothers me more than anything else is that dentistry and people in dentistry don't think they can charge anything unless they're doing porcelain and doing not minimally invasive dentistry, but extensive invasive dentistry. That to me is BS. You got to get paid for the service that you do. You really ought to get more. You want to know the truth. That's the way Bud Mopper feels. That's the way I always charge in my practice. That's the way you have to approach it. That's the way we have to approach it with our own organizations. You cannot undercharge. You undercharge and you'll underdo. That's not what I'm all about.
Okay. Here's a good one from Amir Basmaji. When you place opaquer over a hybrid, do you first light cure the hybrid and then add opaquer? Or do you
yes, you always, in each layer, you polymerize, and then you add the opaquer and polymerize.
Okay.
Then you add tint and polymerize. Then you add the microfil and polymerize. Then, that's the way you do it. Your bonding adhesive, the only time you might not polymerize your bonding adhesive if you're doing an internal repair or something like that, then you may place within the margins of what you bonded. Then you, say it's a pit or something like that, then you would go ahead and put on bonding agent. Don't cure it, air thin it, put on your composite, and then sculpt it, shape, and then polymerize.
And buddy, we have a ton of questions, and we're just about out of time. So I want to give you an opportunity to go ahead and wrap up this session with your webinar series.
Okay, we've got a lot to go through, and I'll show you just what we're talking about. And I really enjoyed this, and we'll add more sessions if it takes more sessions. I'll do anything, because I think, like I said, bonding is underappreciated, underutilized, undertaught, and I'm out to teach it so that you guys can do it and get the most out of it. I'll show you anything you want. I'll be on here as long as you want. We're going to have an extra session to answer questions. If it takes more to show technique, we'll do it. And so our next session is going to involve what you see on the screen here. And it's been my pleasure to present this this program to you. It's my love. It's been my passion all my life, and that's what's kept me alive and kept me strong, and kept me doing what I do. So I want to thank each and every one of you. I want you to be healthy, strong, and happy, and I hope to see you the next time. Can you hear me, Bennett?
Yeah, I think we're all set, buddy.
Okay.
All right.